Welcome back to part 4 of Americans Against Language Barriers Mental Health Interpreting Training series with me, your instructor, Kelly Gretch Henriquez. I know this one has been long awaited, much anticipated. I will say that this is, without contest, the most detailed, most involved, most highly researched CEU course or presentation I have probably ever done in my career. So you all are in for a treat. I hope you enjoy it. So I hope you've also enjoyed the first 3 parts of the series that have focused on the role of the mental health interpreter, interpreting in the U.S. mental health care system, and mental health interpreting techniques for the medical interpreter. Today we're going to be talking all about mental health terminology. So while this presentation is being given in English, I will be giving you the tools you need to find equivalent terms in your target language, as well as best practices for looking up terminology in general. So without further delay, let's get started, shall we? So before we get into the nitty-gritty of defining mental health terminology and clearing up common misconceptions about finding them, it makes sense for us to talk about finding translations for terms. I could drop all the knowledge on you about mental health terminology in English, but it doesn't mean much if you don't know how to find translations for these terms. Other considerations that I could give a whole other CEU series on: studying and storing terms. We won't go over this today, but it's important to keep in mind. Even if you know how to find translations of terms, there still comes the matter of figuring out the best way to store them. Looking up a translation of a mental health term once and forgetting about it means nothing. You have to be able to refer back to it later. In addition, it doesn't make a lot of sense to have a whole long list of terms or even a fancy custom glossary unless you have a way to study them. Think about it this way. Whenever we're interpreting, we don't look up every single medical word that is uttered. It's time-consuming. It's much faster to memorize those terms to be able to recall them when you need to. And the only way you're going to recall these terms is if you study them. So, we have to have a sort of system figured out before we start with learning about terminology. We need to establish a tried and true process for translating mental health terms first. But I'm going to leave it to you to figure out the best way to store those translations and also figure out how you're going to be studying them. Those last 2 points are probably going to be closely connected. The way you store terms is likely going to determine how you're going to be studying them. There are many existing training courses about these topics, so again, I'm not going to go over these points, but I highly encourage you to keep this in mind moving forward. So let's move on to what I will tell you all about: translating mental health terminology. So the question I'm expecting: Kelly, where can I go online to type in mental health terms and find their translation in my target language? That's a question with anything but a simple answer. To cut a long story short, there isn't a searchable, multilingual glossary covering all mental health terms and topics in all languages. The fact is, you're going to have to combine resources and usually check more than just one to verify your translation. There are a few great services that function as multilingual glossaries covering a wide variety of terms, but they're not specifically focused on mental health, which means the terms may not be available or you'll have to do a lot of digging. Keep in mind here, we're talking about looking up terms, not learning about mental health topics in your target language, which is honestly a great way to learn a lot of great mental health terminology in one sitting, but not so great for term lookup. So I know this isn't exactly a scientifically validated way to look at linguistics, but I do find it's helpful to consider sources on a scale from kind of colloquial to technical when determining how to look them up. So if we're looking at medical terms, for instance, when referring to blood sugar, a more colloquial way of putting it is sugars, as in, my sugars have been really high. I think this might be one of those things that is more common in the southern United States. Blood sugar would be a little bit higher register, but not quite technical, whereas blood glucose would be the more sort of technical term. Like I said, with mental health terminology, there really isn't any dedicated mental health source that I'm aware of that you can go to and search all these terms. So you have to combine sources that aren't specifically tailored to translating mental health terminology. Oftentimes, I use word reference as my first kind of quick and easy source for colloquial and not too technical terms. Keep in mind, though, that I'm a Spanish interpreter, and being a pretty common language, all of these resources I'm going to mention have options for Spanish. Word reference only has translations for the following languages at this time: Spanish, French, Italian, Catalan, German, Dutch, Swedish, Russian, Portuguese, Polish, Romanian, Czech, Greek, Turkish, Chinese, Japanese, Korean, and Arabic. So you want to make sure when you're using word reference, you have this word reference tab here. That's great. It's kind of like crowdsourced though, so sometimes it's not going to be 100% correct. I always check the Collins tab. So fortunately, you can switch back and forth between the word reference and the Collins tab to get a kind of full picture of what a term means. That being said, this brings up an important point in general when looking up translations of terms. Always verify between multiple sources. The more sources you verify with, the more of a complete understanding you're going to have of the context of the translation given. Another source I really like to use, and this is really across the board, is Turing. It's fantastic for idiomatic expressions, colloquialisms, and slang. And if you think mental health doesn't have these, you're wrong. I don't really use Turing for much of those basic everyday terms. There are much better sources for technical terms. So word reference actually didn't have this particular phrasing, mental block, available. Aside from in the forums, which can be kind of a hit or miss when it comes to finding like technical terminology. But here we can even see kind of like a regionalism from Chile, which is kind of cool. So it actually tells you these kind of colloquial translations, where they originate. So you'll know, okay, well, this is super particular to Chile, might not necessarily work with patients from, let's say, Central America. They may not understand it. They might not. So next up, we've talked about word reference, we've talked about Turing. For looking up terms that are a little more specialized, but often not too specialized, I might go to Prozy's term search. This is at prozy.com/search. Now you can find more generalized terms, including colloquialisms and everyday terms here. But the real gems with Prozy, I think, that you can't find anywhere else are really specific, multi-word concepts that aren't highly technical. Though you can still find some highly technical terms here as well. So breakthrough manic episode. It's a pretty specific term. Even though I can find breakthrough and manic and episode separately on both word reference and Turing, this specific combination of words isn't general enough to look up in a more specialized glossary either. Prozy is kind of a niche tool for me, but it definitely serves its purpose from time to time. The really great thing about Prozy is that it basically has every language under the sun as well. But looking at this listing for breakthrough manic episode draws our attention to a common problem and a tool we can use to resolve it. If you look here, there are two generally agreed upon translations for breakthrough manic episode. So if there are two potential translations of these terms, what do? If you love data and graphs like I do, you're going to love Google Ngrams. So if you go to books.google.com/ngrams, that's N as in Nancy, you can actually see how common a term or phrase's usage is over time. It doesn't work with all terms. It works off of Google Books, so as you can imagine, if your target language doesn't have a lot of books available, you may not have the ability to search, or there might not be enough data to draw a statistically significant enough conclusion. You can change the language by going up to the second drop-down below the search bar at the top. So you can see up here at the top, it says English 2019. So here I've decided to look up terms used for the same mental health disorder and how they varied over time in English. Manic depression was what they used to call bipolar disorder. But you can see here that in the 80s it looks like this changed. Manic depressive disorder appears to be less used than manic depression ever was, at least in the database of books Google is searching. It's pretty neat, huh? This is actually incredibly practical for medical interpreters and can be helpful to find the most commonly understood and commonly used terms. But going back to our little chart and our sources for looking up mental health terms, a really reputable terminology database that includes the World Health Organization and UNESCO is the UN Term Portal. It's available in French, Spanish, Russian, Chinese, Arabic, Portuguese, and German. Now, you're not going to find general mental health terms here. This is where you're going to find not only super complex mental health terminology, think psychiatry and psychopharmacology, and of mental health, but also official names of national and international organizations in multiple languages. You can also view multiple languages at once, which is probably going to be super useful for those of you who interpret multiple languages. Now, it may seem like I'm doing this a little bit out of order, but I've actually recently come to love this tool, so I added it a little bit later. Termium Plus. Sounds a little bit like an Arnold Schwarzenegger movie. Anywho, it's actually the terminology and linguistic database of the Canadian government. It's in French, Spanish, and Portuguese. Again, this doesn't have a specific mental health database, but it does have technical terms across different disciplines, including medicine and health. Furthermore, you can see English translations alongside Spanish and Portuguese all at the same time, which I imagine would be super useful for folks who have multiple working languages. So all of the sources we've gone over so far function primarily as glossaries. This last source doesn't function as a glossary per se, but is a useful and reliable source nonetheless. MSD Manuals, also referred to as Merck Manuals, is by Merck & Co., a multinational pharmaceutical company. You've probably heard of it. It's a treasure trove of super useful health information materials with lots of great terminology. It's kind of like Wikipedia, but for medical stuff and more trustworthy. Just like Wikipedia, you can actually navigate to any page and change the language right then and there. It's available in English, Spanish, German, French, Italian, Japanese, Portuguese, Russian, Chinese, and Vietnamese. This is really useful if, let's say, for instance, you're having a hard time figuring out the best translation for the term guided imagery, which is a sort of form of meditation in which you focus and use your imagination to concoct tranquil images in your mind. You can't find the term by itself or are having a hard time, but you know it's a relaxation technique. You can search relaxation techniques in English, then go to the top, see right here, and use the drop-down menu to change the language. And then boom, you have the translated version of the page in your language of choice. Now, this may seem like a kind of convoluted way to get a specific term, but this can be really great if 1, you're running out of options, and 2, you want to start learning terminology related to certain concepts or conditions. Between the sources I've mentioned thus far, you should be able to find most mental health terms. I say most because, well, not because I'm giving you what I feel to be an incomplete solution, but because I'm sure someone out there is going to try and say they weren't able to find something using these sources. Stranger things have happened. Anywho, here are the links to all the sources I mentioned. So for Spanish language interpreters, I actually have on my website, kghinterpretation.com, if you go to my website, and then at the top menu where it says resources, scroll down to where you see terminology resources. There's actually going to be a link there to Spanish language mental health information. And here I have a link shortened by bit.ly. And then you can click on mental health resources in Spanish. Again, these aren't really going to be term lookup as much as they are just kind of reading about different mental health conditions in Spanish. So without further ado, let's get to the nitty-gritty. I'd be remiss if I didn't start with this. What is mental health? Well, mental health is just one part of our health. Just like we have the big umbrella of physical health that includes things like our bone health, eye health, reproductive health, and all those other parts of our bodies, we also have mental health, which is comprised of our cognitive, emotional, and behavioral well-being. Mental health is a big topic, which is probably why I had a hard time organizing this training in a way that didn't feel disjointed without leaving the important stuff out. As you can imagine, mental health has a lot to do with the brain, which is our first wellspring of mental health terminology. Most mental health disorders are generally thought to be the result of some level of brain dysfunction, whether it be minor or major. Now, if you're a practicing medical interpreter, I'm sure you're probably wondering at this point, Kelly, if we're going to talk about the brain then, are we going to be spending this whole time talking about neurology? Not quite. First, we're going to take a look at how neurology, psychiatry, and psychology are a little bit different, just to give us some context before we dive right in. So psychology is focused on all those things that mental health disorders tend to affect: cognition, emotion, and behaviors. It's the study of the human mind. Now, the mind is different from the brain. The brain is the physical, tangible thing. The mind, though, it's not tangible. You can't pick up a mind and hold it. As gross as it is, yes, you can pick up a brain and hold it. Therefore, it's tangible. Psychiatry, on the other hand, is focused more on the intersection of the brain and the mind. The definition of psychiatry versus neurology was a bit of a contentious topic to research, actually. But my favorite definition was one that I found that distinguished psychiatry as being concerned with abnormal voluntary functions. For instance, when you have a mental health disorder like major depression, you may lack the motivation to do the things you once enjoyed doing. Does that mean you're physically unable to move your body to do that thing? No. Now, by no means am I saying folks with depression need to just suck it up, get up, and do those things, but that those things are technically still possible, even if the disorder affects your emotions, thinking, and behaviors in a drastic way. Now, neurology is, like we said, focused on the brain and mostly abnormal involuntary functions. Go to see a neurologist because you physically can't move your legs to get up from the couch to go do the things you once enjoyed doing, despite there not being something physically wrong with your legs, back, etc. And it's thought to originate in the brain. No matter how hard you try, you can't move your legs. Call the neurologist, not the psychiatrist. Now, there is a field called neuropsychiatry that sort of bridges the blurry gap between neurology and psychology. But this leans a little bit away from psychology and focuses even more on the brain. The fuzzy differences between neurology and psychiatry is perhaps best illustrated by the condition known as dementia, as it's not considered a mental illness, but is often classified as both a mental health disorder, such as by the World Health Organization, and a neurological disorder because it stems from neurological processes that often affect cognition, emotion, and behaviors. Both neurologists and psychiatrists treat patients with dementia, with a lot of overlap in terms of the types of symptoms they seek to manage. So now that we've got that out of the way, we can talk a little bit about the brain. We're not going to do anything fancy, just a general overview of some of the basic terminology, including structures within the brain and what they do. When we're interpreting for mental health professionals, it's not uncommon for providers to talk about the underlying biological and neurological mechanisms responsible for mental health conditions and their symptoms, so you should be somewhat familiar with them. At the most basic level, the main part of your brain, the cerebrum, also known as the cerebral cortex, is divided up into two halves or hemispheres, the left and the right. This makes sense because the prefix hemi literally means half, and while the brain isn't necessarily a perfect sphere, it's sphere-like enough, I suppose. It's generally thought that these two hemispheres function a little differently, with the right hemisphere being considered our creative side and our left hemisphere being considered the more logical side of our brain. A little bit of an oversimplification, but that's generally how they're conceived of. Now, in the center of the brain is a structure called the corpus callosum that connects the two hemispheres and allows them to communicate. In essence, it's a thick bundle of nerve fibers that serves as a sort of neural highway between the left and right hemispheres of the brain. So when we're talking about hemispheres of the brain, each one can be further divided up into the 4 lobes of the brain. So first off, we have the frontal lobe. So this is where we have our cognitive functions controlling voluntary movement and activity. So the frontal lobe is also incredibly important when it comes to reasoning, problem solving, controlling inhibition, self-regulating behaviors, and controlling emotions. People who have damage to their frontal lobe may experience difficulties with controlling behaviors or emotions, for instance. Next up, we have the parietal lobe. This processes temperature, taste, touch, and movement. Parts of the parietal lobe, though, also play a role in language comprehension. The occipital lobe is mainly responsible for vision. It's also responsible, though, for how we perceive body language, such as postures, expressions, and gestures. The temporal lobe processes memories and connects them with our senses like taste, hearing, vision, and touch. So the temporal lobe is located near the ears and also aids with language comprehension and production. So next up, we're going to talk about the limbic system. So the limbic system is the part of the brain that plays a huge role in behavioral and emotional responses. So you often hear about these parts of the brain a lot in psychiatry, or even when a psychologist, therapist, or counselor describes how certain processes in the brain play into emotions. The structures of the limbic system, primarily the amygdala and hippocampus, are located just below the big part of the brain we just talked about, the cerebral cortex or cerebrum, and above the brainstem. So it's kind of like sitting in the center of the base of the cerebrum. The amygdala is called the amygdala because it's in the shape of an almond, which is why if you're a Spanish speaker, you know this word is also used for tonsils, though those tend to be more oval-shaped. The amygdala, in the brain now, plays a central role in emotional responses, especially those involved in pleasure, fear, anxiety, and anger. It also attaches emotions to memories as well. So emotionally charged memories, as you can imagine, tend to stick with us better than non-emotionally charged memories. So in a way, this structure can play an important role in memory retention. The other main structure of the limbic system, the hippocampus, is considered to be the memory center of the brain. We form episodic memories here that are then organized and sent across to other parts of the cerebrum. It also helps us attach and associate senses with memories. So for instance, this might be why the smell of fresh cut grass might remind you of summertime. The hippocampus also helps with spatial orientation as well. Now the thalamus and the hypothalamus are the lesser structures of the limbic system. The thalamus acts as a sort of messenger for sensory information to other parts of the cerebrum. It also plays a big role in sleep. Whereas the hypothalamus, now it's called hypo because it sits below the thalamus, hypo, below. It regulates the production of important hormones in the pituitary gland and endocrine system. The hypothalamus also regulates some important functions of the body called somatic functions, such as thirst, hunger, mood, and even body temperature. To illustrate why we're learning about these structures and why they're often talked about in mental health settings, we're going to have a brief aside to talk about what many of us already know as the fight or flight response. This is a response in our bodies that has evolved as a sort of survival instinct. Our ancestors would face a threat from a wild animal, and the fight or flight response developed so they would automatically be able to respond to that threat in such a way that would increase their likelihood of survival. This actually happens so quickly that a lot of the time we don't even realize it's happening and we react before we even think about what's going on. For instance, if you're crossing the road and a car is about to hit you, sometimes you jump out of the way before you even have a chance to think about it. To put the process simply, you are faced with something threatening, or that you perceive to be threatening. For instance, I am deathly afraid of needles. I might perceive that to be threatening if someone comes up to me with a needle, even if it's a doctor. Your amygdala automatically reacts because it's the part of the brain responsible for perceiving fear. This then sends a signal to your hypothalamus, which, as we discussed previously, regulates the production of important hormones and thirst, hunger, mood, body temperature, etc. Your hypothalamus then stimulates the ANS, or autonomic nervous system, which causes your body to release the hormones adrenaline, also known as epinephrine, and cortisol, which is known also as the, quote, stress hormone. After the release of these hormones, your body begins to prepare itself to face or fight the threat, or flee from it. Hence this reaction being called the fight or flight response. So this is where you have increased heart rate. Now your heart rate increases to bring oxygen to muscles so you can be prepared to fight or flee. It increases your breathing rate because in order to increase that oxygen supply to fuel that surge in oxygen to your muscles. Your pupils also dilate. This allows you to see better by letting more light into your eyes. And then your blood pressure raises. Your blood actually gets thicker to increase clotting factors in case you get injured. This is also accompanied by a decrease in blood flow to extremities, because remember, a lot of blood is being redirected to your muscles, and a decrease in pain perception. So this is in case you get hurt, you can still keep on fighting. This is what your body's thinking. So your body automatically does all these things to respond to a perceived threat. Now, what does this have to do with mental health? Well, you'll often hear providers talk about this response because people who experience things like trauma or have an anxiety disorder, for instance, they might have an overactive or exaggerated stress response, even towards non-threatening situations or stressors. So, for instance, a patient might ask a question like, "Why do I feel this way?" Or have a hard time wrapping their head around why they react the way they do. Why do my hands start shaking? Why does my heart start racing when XYZ happens? Why do they feel their heart pounding or short of breath facing normal everyday stressors? The provider may explain some version of the fight or flight response, ranging from a simple explanation all the way to a detailed, high-registered mini-science class. And you, as the interpreter, are there to interpret this to the patient. So by understanding yourself and being familiar with these terms you may come across, you'll be better prepared to then interpret a provider's explanation, of which this is just one possible example. So I feel like we got a little deeper there into neurology and biology than you were probably expecting. But we're going to go back to something a little bit more basic now with relation to the brain: neurons. Neurons are the cells that function as the basic working unit of the brain and nervous system. They look like little trees. Happy little trees, as Bob Ross would say. They're like the communication network of the brain and nervous system, all working together to send information by means of electrical impulses and chemical signals. Now, neurons don't physically touch each other. There's actually a small gap between them called a synapse. Meaning if they want to communicate with each other, they have to send little messengers across, which brings us to neurotransmitters. These are the chemical messengers of the nervous system. There are different types of neurotransmitters that play different roles and can affect mood, emotion, thought processes, and even appetite and sleep. So here are some examples. You've probably heard of serotonin. It affects a lot of bodily functions, including sleep, appetite, and mood. Common medications for depression focus on blocking the reuptake or reabsorption of serotonin, which increases the amount of serotonin in the body. This is because many people with depression often have low serotonin levels. Dopamine is what a lot of people call the feel-good chemical, or the feel-good neurotransmitter. It's involved in reward, motivation, and even addiction. It also plays a big role in the part of the brain that coordinates body movements, which is why Parkinson's is closely linked to the loss of neurons that generate dopamine. In terms of mental health, some schizophrenia symptoms can be explained by too much dopamine in certain parts of the brain, such as hallucinations and delusions. Some research even suggests that low dopamine levels may be the cause of ADHD, though we're not entirely sure. Some experts believe that this is one of 3 neurotransmitters that play a role in depression as well. Glutamate is the most common and plentiful neurotransmitter that plays a role in cognitive functions and learning. We know that excessive glutamate plays a role in Alzheimer's, but problems with the production or use of glutamate may play a role in depression, schizophrenia, autism, and/or OCD. All of these are conditions we're going to be talking about. Epinephrine is a unique one. It's also known as adrenaline, which we've talked about before in the fight or flight response, and it's both a hormone and a neurotransmitter. So if you remember, it's a stress hormone, and it's one of the hormones released by the ANS. What does that stand for? The autonomic nervous system, as part of the fight or flight response. So just like epinephrine, norepinephrine, aka noradrenaline, is both a hormone and a neurotransmitter. It's also a stress hormone and also plays a role in the fight or flight response. Some experts believe that this is one of the 3 neurotransmitters that play a role in depression, just like dopamine and serotonin. Low levels of norepinephrine tend to be found in people with major depressive disorders, whereas high amounts have been present in people with ADHD. Later on in this course, we're going to be talking a little bit more about norepinephrine. Lastly, we have our endorphins. They're another one of those neurotransmitters that are also a hormone. It inhibits pain signals, and it's responsible for feelings of euphoria. Endorphins also promote the release of dopamine, which we now know affects mood, and is one of the 3 neurotransmitters thought to be involved in depression. Some opioids actually block the same pain receptors as endorphins do, but generate way more dopamine in response. The body becomes accustomed to these super high levels of dopamine to the point where the release of dopamine by endorphins just doesn't cut it anymore. Additionally, self-harm or self-injurious behavior can cause an endorphin rush that results in euphoria, causing some people to rely on self-harm to cope with emotional stress. Now, these aren't all the neurotransmitters that exist, just the ones that you're most likely to hear about in a mental health setting. And while the exact mechanisms of many mental and behavioral health disorders is not entirely known, we can see that many of these neurotransmitters have either been proven to play a role in certain mental and behavioral health conditions or are suspected of playing a role. This is why it's important to know about neurotransmitters, or at least having heard of them. Many times when interpreting for psychiatrists, I've had to interpret explanations involving neurotransmitters to patients who are taking psychiatric medications. So as you've probably noticed, we've already started to bring in some mental health disorders into this presentation. Now we're going to look at them in depth. When I say in depth, I mean in depth. For this section, it's going to be super helpful to take notes on any terms you may not be familiar with, how to interpret into your target language. And I'm not just talking about the conditions themselves. I'm talking about the symptoms. I'm talking about any unknown words that you do not know, either in English or you do not know how to interpret into your target language. You start that list now if you haven't already. So some of these terms for these conditions, as well as their accompanying symptoms, might very well be completely new to you. And so you got to remember, I'm not going to give you the translations for these terms. I've given you the tools to search for them yourself. Going to be on you to do it. Now, before we can talk about mental health disorders and their classifications, I'd like to briefly mention the DSM and the ICD. So these are considered the 2 main authorities on the classification of mental health disorders. So you gotta know about the DSM. The DSM is the Diagnostic and Statistical Manual of Mental Disorders. It specifically classifies mental health disorders and includes descriptions, symptoms, and criteria for diagnosing mental health disorders, whereas the ICD is the International Classification of Disease. Now, this is maintained by the World Health Organization, and it classifies more than just mental health disorders. If you've ever worked in an administrative capacity in the U.S. healthcare system, or any health system in a country that is a member of the World Health Organization, you've likely seen ICD-9 or ICD-10 codes in EMR or EHR systems. They're combinations of letters and numbers used as kind of shorthand for different diseases and diagnoses. Now, the current version of the DSM is the DSM-5, as of the time of this training, and it was released in 2013, whereas the current version of the ICD, technically, is the ICD-10. Now, the ICD-10 was first adopted in 1994, a long time ago. But the ICD-11 is actually poised to be adopted in 2022. For the purposes of this training, I'm going to be relying mostly upon the ICD-10 classifications for mental health disorders. While the ICD-11 and DSM-5 are more current, the fact is that the majority of health systems I've interacted with as an interpreter seem to operate on the classifications as laid out in the ICD-10. This is likely because quite a bit of mental health interpretation takes place in hospitals. So they're likely going to have to rely on a coding and classification system that doesn't focus on just mental health. Furthermore, ICD-11 has not yet been adopted. And even after it's rolled out in 2022, it's not like everything's going to change overnight, right? It's going to take a little while for health systems to catch up with the changes. To illustrate this point, ICD-9 was still used in the US for covered entities under HIPAA until 2015. Remember, ICD-10 came out in 1994, but some health systems were still using the ICD-9 in 2015. That being said, I will be drawing in some information from the up-and-coming ICD-11 and the DSM-5 for comparison, as well as outdated terminology. I also like conceptualizing of mental health disorder classifications in this way because many of us who have taken psychology or learned about it in some capacity during our schooling, myself included, we're being taught some of these outdated terms and ways of conceptualizing of mental health disorders. For instance, I was even taught some of the information I'll later point out as outdated in college as late as 2016. This just highlights the importance of continuing education in an ever-evolving healthcare and mental health care landscape. So to begin with, what is sometimes referred to as organic mental disorders, but is also called neurocognitive disorders, involve cerebral dysfunction due to brain disease, brain injury, etc. But that brain disease or injury is not as a result of substance use. We'll talk about that later. Dementia is one example of this type of disorder. A lot of people think of dementia as one condition, but it's actually an umbrella of different types of conditions. Many people with dementia have a disease like Alzheimer's, Parkinson's, or Huntington's that cause it. Vascular dementia is often caused by stroke. And yes, dementia is often, but not always, considered to fall under the umbrella of mental health. It's a brain disorder that causes issues with cognition, memory, and decision-making. Oftentimes, when I go to interpret at a local healthcare facility that provides mental health services, I'm sent to the geriatric psych unit, and many patients are there primarily due to dementia. Many times, these patients experience a state of confusion that can begin later in the day or even at nighttime, and it's called sundowning. It doesn't necessarily have to be confusion, though. A patient can become anxious, aggressive, or even wander off. Now back to our examples. Organic amnesia, also known as organic amnesic syndrome, is simply amnesia, aka a partial or total loss of memory due to structural damage of the brain. Delirium, on the other hand, that's a good term, by the way, delirium for mental health terminology, is a disturbance of consciousness and awareness. And yes, so here we have substance use disorders. Substance use disorders are mental health disorders. The ICD-10 calls substance use disorders mental and behavioral disorders due to psychoactive substance use. So if you remember on the previous slide, brain dysfunction due to substance use is not part of organic mental health disorders, but instead part of this category. This category further uses subdivisions of the severity of the substance use, but we'll get into this in more detail in a further installation of this series. This category also specifies subcategories of substances, such as alcohol, opioids, cannabinoids, sedatives or hypnotics. So these include our benzodiazepines, also known as benzos, cocaine. Cocaine is a stimulant, so they also have a category of other stimulants. This includes amphetamines and even caffeine. Hallucinogens. This includes our classic hallucinogens like LSD, psilocybin, DMT, peyote. It also includes dissociative drugs like PCP, ketamine, and DXM. There's also tobacco, a category called volatile solvents. So this you might have heard of as inhalants. So like glue, compressed air, things like that. And then we have the category of multi-drug use and other. So this is basically a miscellaneous category. Our third category in the classification of mental and behavioral disorders is schizophrenia, schizotypal, and delusional disorders. Before we get into the disorders, it's helpful to understand their commonalities, including impairment in perception of reality and alterations in behavior. They may or may not include specific symptoms like persistent delusions, persistent hallucinations, disorganized thinking that often comes out as disorganized speech. So yes, disorganized speech can be something that we may need to interpret, which I've actually discussed in an earlier installation of this series how to handle that. What's called grossly disorganized behavior. So when we say grossly, it just means very, very odd or unpredictable behavior. Or even what's called a, quote, flat affect. So a flat affect, your affect is basically the way you conduct yourself or even your facial expressions. So a flat affect just basically means you're expressionless or appear apathetic without emotion. I actually pulled this list of symptoms from the ICD-11, you remember the one that's coming out in 2022? Because our understanding and conceptualization of this category has changed quite a bit since 1994 when the ICD-10 was adopted, especially that of schizophrenia itself. Schizophrenia, which is basically just a grab bag of all these symptoms we just mentioned, used to be divided into 5 subtypes, both in the ICD-10 and the DSM-4. However, these categories are no longer used, but their symptoms have been rolled into the main category of schizophrenia. For instance, what used to be called catatonic schizophrenia is no longer considered a subtype of schizophrenia, but catatonia, the inability to move normally, is one potential symptom of schizophrenia as a whole. Now, by psychomotor disturbances, we mean strange movements, or movements that serve no purpose at all. If a person with schizophrenia has delusions and or hallucinations, which was once considered to be its own subtype of schizophrenia called paranoid schizophrenia, these delusions and hallucinations will be persistent. So schizotypal disorder resembles schizophrenia, but may be considered a sort of personality disorder. Sometimes you might even see it listed as schizoid personality disorder. The symptoms are not as intense or long-lasting to merit another diagnosis in this category, such as schizophrenia or delusional disorder. This one's kind of self-explanatory, I think, because the main symptom is one or more delusions. These delusions are persistent and can even last a lifetime. Many of the characteristic symptoms of schizophrenia, such as persistent hallucinations, are not present in this disorder. Our fourth category of mental health disorders is mood or affective disorders. As you can guess by the name, these are characterized by patterns of mood episodes over time. For instance, bipolar disorder. While it's a disorder on its own, it's actually a category of related disorders as well. As we actually already discussed in our glossary section, this condition used to be known as manic depression or manic depressive disorder. This is because it's characterized by shifts in moods known as episodes, ranging from mania to depression. These episodes can last from days to months. So mania, or a manic episode, is when a person with bipolar disorder feels elated or up. They might not necessarily feel happy. They could even feel irritable or just reckless and prone to engaging in risky behavior. Someone experiencing a manic episode might even have trouble with insomnia. Hypomania, on the other hand, is just like it sounds. We should all know what the prefix hypo means at this point. It just means a lesser version of mania, a less severe form of mania. Depression or depressive episode is, I feel, fairly self-explanatory. It's kind of like the opposite of mania, but not exactly. So instead of feeling up, you're going to feel down. Instead of being elated, you might feel sad. You might lose interest in things that you once found to be enjoyable. All of those classic symptoms of depression. And a mixed episode is just that, a mix or a combination of these types of episodes. The DSM-4 actually introduced different types of bipolar disorder, which will be reflected in ICD-11. So bipolar and related disorders are one subcategory of these mood and affective disorders in the ICD, both 10 and 11, but in the DSM, bipolar and related disorders is its own category, along with depressive disorders, which is also a subcategory of mood disorders in the ICD. This one's pretty self-explanatory, I think. Just like depressive episodes, it's marked by depression, and it can include the following symptoms: sadness, irritability, emptiness, a loss of pleasure, and even insomnia. However, depressive disorders are not characterized by mania. If someone has mania, they don't have a depressive disorder. Category number 5 in the ICD-10 is called, quote, neurotic, stress-related, and somatoform disorders. But this category is now conceptualized very differently in the psychiatric community. I'll go over some categories of disorders that once belonged in this category here in a moment, but first, for terminology's sake, I want to kind of examine what some of the terms in the title of this category mean before proceeding, because you still may hear them and have to interpret them. Neurotic disorders is a category that really isn't in use anymore in the professional psychiatric community. However, you might still hear terms like neurotic behavior or even neurosis, plural neuroses. Generally speaking, neurosis is considered to be chronic distress without classic reality distorting symptoms like hallucinations or delusions, whereas psychosis is chronic distress that does have that sort of disconnection from reality. Oftentimes we'll hear the word anxiety used these days instead of neurosis. Stress-related is fairly self-explanatory, and we'll get into some of those disorders here in a moment. But somatoform is a word a lot of folks haven't heard. It's actually still in use, but you're more likely to hear somatic symptom disorders or somatization syndrome. These are mental health disorders that have physical symptoms but can't be explained by a medical condition. And we'll talk a little bit more about somatoform disorders, somatic symptom disorders, or somatization syndromes here in a moment. So this category we have of neurotic, stress-related, and somatoform disorders is now a bunch of different categories in both the DSM and ICD-11. The first of which is anxiety and fear-related disorders, according to ICD-11. Anxiety disorders are those disorders characterized by anxiety, which we all know is this feeling of intense worry or unease that can have symptoms like rapid heartbeat and shortness of breath. Think of that fight or flight syndrome. Generalized anxiety disorder, or GAD, is just that, a disorder characterized by persistent anxiety. Not necessarily towards any specific thing. Doesn't necessarily need to be triggered by anything in particular, which is why the ICD-10 even uses the words, this is a great term, free-floating, to describe the anxiety that comes with this condition. Social anxiety disorder, on the other hand, is a disorder in which anxiety is provoked specifically by social situations, such as talking to others or even being observed while doing things like eating or drinking. Oftentimes, folks with social anxiety disorder are concerned that they'll make a fool of themselves, or are even anxious about others perceiving their anxiety in social situations. Sometimes, social anxiety disorder is also referred to as social phobia. You'll notice that generalized anxiety disorder is also referred to as GAD. But, and this is important, social anxiety disorder is generally not referred to as SAD. This acronym is often reserved for seasonal affective disorder, which is a type of mood or affective disorder that is related to changes in the seasons. The last anxiety disorder we're going to mention is panic disorder. This disorder is characterized by sudden and repeat panic attacks. A panic attack is an episode of intense fear, with symptoms that include heart palpitations, shortness of breath, chest pain, dizziness, or even feeling like death is imminent. A lot of folks think they're having a heart attack or dying when they get panic attacks. Now, you can have panic attacks with other anxiety disorders as well, but with panic disorder, they can happen anywhere, at any time, and oftentimes the unpredictability of these attacks, the fear that they're going to happen, are an actual cause for anxiety and distress just by themselves. Panic attacks are also not uncommon in disorders in our next category, fear-related disorders, or what you likely have heard of as phobias. Now, a phobia is an intense and irrational fear of something. As a result of this fear, you avoid that thing and it causes you extreme distress. Now, you've likely heard of agoraphobia. A lot of people think this means fear of leaving your home, which in some people who suffer from agoraphobia, this does happen, but it's a general term, an umbrella term, that really just applies to anxiety in situations where people think there is no escape or their environment is unsafe. For instance, experiencing anxiety in wide open spaces or being in a mall might also be considered agoraphobia if you have a fear of those things. The person may not necessarily be afraid to leave their home, but there may be certain spaces they will have anxiety entering or being in. And now we get to a big pet peeve of mine. Obsessive compulsive disorder, or OCD, is not something everyone has. I don't know what's happened in the past 15 years, but everyone and their mother now occasionally says something like, "Oh, that's just my OCD coming out." Please stop. Please. As someone with a disorder in this category, I'm here to tell you making statements like this is not okay. OCD and its related disorders can be absolutely debilitating. So unless you've been diagnosed with OCD, please stop saying you're a little OCD. It's not cute and it's not funny. Now that we've gotten that PSA out of the way, back to your regularly scheduled program. Obsessive compulsive disorder is, as you guessed it, characterized by repetitive obsessive thoughts and or compulsive acts. Some people have one, some people have the other, and others have both. Obsessive thoughts may even be images or impulses and are often accompanied by anxiety. Some folks with OCD engage in compulsions to try and sort of neutralize these obsessive thoughts. When you have a compulsion, you often have this irresistible urge to do it. Oftentimes, when people think about OCD, they think of things like repetitive hand washing or rituals like counting, checking things, walking a certain way. These obsessions and compulsions are often time-consuming, taking more than an hour out of someone's day. And patients with this disorder experience a fair amount of distress because of them. They may try very hard to resist them, but are very rarely successful. And there are some disorders related to OCD. Sometimes you'll hear them referred to as OCD spectrum disorders. Body dysmorphic disorder, or BDD, involves repetitive thoughts about flaws in appearance. Sometimes these flaws may not even be perceived by anyone else. They might even be imagined. To be clear, this is not an eating disorder because eating is not generally affected. Oftentimes, BDD focuses on a specific body part or parts, and the person may engage in actions to mitigate the anxiety caused by them. For instance, avoiding social activities because the person with BDD believes their acne or a particular facial feature makes them hideous. Someone could even have BDD related to, quote, feeling fat, but not really have an eating disorder. Instead, over-exercising or just avoiding social activities. Hypochondriasis. We've all probably heard the word hypochondriac. Well, hypochondriasis is a mental health disorder in which someone is consistently worried that they have a serious or life-threatening condition. It might also be accompanied by compulsive behaviors like constantly checking WebMD or going to the doctor. You've probably heard of the show Hoarders, and it's all about folks with hoarding disorder. Hoarding disorder is a mental health disorder in which the person simply cannot stop collecting possessions. Oftentimes, these folks may collect certain things, but most of the time they can't bring themselves to discard their possessions. It may result in an unsafe living environment and often results in significant distress. Not only do people hoard objects, inanimate things, but sometimes we even see folks who hoard animals or living things. There's also a category of OCD-related disorders that is called body-focused repetitive behavior. These are conditions like trichotillomania and dermatillomania. Those are big words. And involve repetitive, often destructive behaviors geared towards the hair and skin. Our next category is stress-related disorders. But before we go any further, I wanted to explain the difference between stress and trauma. These two terms are thrown around a lot, but sometimes incorrectly used interchangeably. It's important to know the difference as an interpreter when you're interpreting these terms. Stress is simply how the body and brain respond to any demand. Stress isn't always bad. Have you ever heard of anyone saying that they perform well under stress? This just emphasizes that all stress is a response to pressure. That pressure being a stressor. So stress can be a response to anything, really, as long as it's something that someone would reasonably consider to be demanding. Trauma, on the other hand, is a little bit more intense. All trauma is stress, but not all stress is trauma. I'll say it again. All trauma is stress, but not all stress is trauma. So trauma stems from an adverse emotional response, and it comes from exposure to one particular incident or even a series of events that are disturbing or life-threatening. Again, all trauma is stress, but not all stress is trauma. The difference is in the degree and the nature of the precipitating factor, whether it be a stressor or a traumatic event or events. Post-traumatic stress disorder, or PTSD, is the big disorder in this category. It may develop following exposure to trauma and is characterized by re-experiencing or reliving the event via intrusive thoughts, nightmares, or flashbacks, avoidance of thoughts and memories of the event or events, and things that remind the person of them, and what are often referred to as alterations in arousal and reactivity. For instance, someone with PTSD may have what's called, and this is a good terminology word, hypervigilance, which is basically constantly being on alert. Another example of an alteration in reactivity would be getting startled easily or getting very startled by seemingly small things. Dissociative disorders are marked by dissociation, a sort of disconnect from the self or reality. It can disrupt some or all of these: identity, sensations, perceptions, affects, thoughts, memories, ability to control one's own body and behavior. To give you some examples of what this means, I'll briefly explain some of the disorders included in this category. Dissociative amnesia. I feel is pretty self-explanatory. Think Bourne identity. Jason Bourne can't remember who he is. It doesn't necessarily have to be your entire identity, but it can be bits and pieces of it, or just important information about yourself. Jason Bourne didn't remember his name, for instance. Depersonalization disorder, on the other hand, is feeling detached from yourself, as if whatever you're doing or feeling is like someone else is doing it. You still remember your name, you still remember important things about yourself, just you feel like the actions that you engage in aren't your own actions. You feel like a stranger in your own body. Dissociative identity disorder, or DID, was once known as multiple personality disorder. This gives us some insight into what it is, alternating between identities. The person may feel like there are multiple people inside of them, vying for control over their body, and as a result of switching between personalities, they might even have gaps in memory. Now keep in mind that these are mental health disorders, meaning they're pervasive and often require treatment. Many of us may experience dissociation from time to time. This is actually a symptom of some other mental health disorders as well, occasional dissociation. Or some of us might even experience what feels like what some of us call an out-of-body experience. But just because we have one of those doesn't mean we have one of these disorders. I previously pointed out that this category that used to be one big category, neurotic, stress-related, and somatoform disorders, is now conceived of as multiple categories, and somatoform disorders was one of them. Now, somatoform disorder is referred to as somatic symptom disorder, and is a manifestation of physical symptoms that don't have any apparent physical cause, despite repeated medical tests. Somatic symptoms and related disorders may also be referred to as disorders of bodily distress or bodily experience. So you have a symptom or symptoms, such as pain, and doctors have done all sorts of tests looking into the cause, but they can't find anything. These symptoms are causing you distress, but there's no medical reason for you to have them. As you can imagine, this disorder is sort of controversial in nature. Many professionals in the psychiatric community are hesitant to diagnose a patient with this disorder, especially because they're concerned they may be labeling someone as mentally ill who may not be. Medical science isn't perfect, and especially in the United States healthcare system, diagnostic testing to pinpoint the exact cause of a physical symptom can be incredibly expensive, serving as a sort of barrier to a diagnosis. Now remember, somatic symptom disorder is a disorder all on its own, but this category of somatoform and related disorders can include conversion disorder, or CD, which is sometimes also called functional neurologic symptom disorder. This one is particularly distressing because it has neurological symptoms such as numbness, blindness, or even paralysis, seemingly without cause. We've already discussed hypochondriasis under OCD and related disorders. Some classification systems place this disorder in this category. And also BDD, or body dysmorphic disorder, which we've previously discussed and was also included under OCD and related disorders. Some classification systems also place this disorder in this category. Like I said, inclusion of these disorders in this category largely depends on the classification system we're looking at, like ICD-10 or 11, or the DSM-4 or 5. This just highlights the controversial and often debated nature of this category. We also have our feeding and eating disorders. These are characterized by abnormal eating or feeding behaviors that can't be explained by another health condition and are not developmentally appropriate. For instance, little kids might stick non-food items in their mouth, but this is not necessarily an eating disorder. Another important note about eating disorders is that the eating or feeding behaviors are not culturally sanctioned or culturally appropriate. The interesting thing about eating disorders is that there may be a big cultural component to it. Here in the United States, with a major emphasis on being thin, the incidence of certain eating disorders is generally higher. Some behaviors folks with eating disorders may engage in are binging and purging. First off, binging is spelled B-I-N-G-E-I-N-G. There's an E in there. Otherwise, it's binging, which is entirely different. Binging, to binge, is to lose control over eating. Either you can't stop eating or you can't limit how much you eat. It might even be binging on a certain type of food. Purging, or to purge, is to attempt to induce weight loss. A lot of people think this is just via vomiting, but purging can also be taking laxatives, over-exercising, any number of things. Our first eating disorder is anorexia nervosa, colloquially referred to as anorexia. It's characterized by having low body weight, or even just rapidly losing weight. This is, of course, not due to medical reasons, such as, cancer or a thyroid issue. It's purposeful, and the person will engage in behaviors designed to prevent weight gain, like purging or severely limiting their calorie intake. We also have bulimia, which is usually one of the two main eating disorders folks know about. It's a cycle of binging and purging. Cool fact, if you're a Spanish interpreter, anorexia is often colloquially referred to as Ana, and bulimia is known as Mia. Binge eating disorder is just like it sounds. It's characterized by binging. This differs from bulimia in that it's not a cycle of binging and purging. Lastly, we have pica. This is a disorder in which the person engages in the consumption of non-food items, such as dirt or paper. There's even a version of this that's often referred to as Rapunzel syndrome, in which people eat their own hair. These folks often also have a condition we've previously discussed called trichotillomania, or hair pulling, which is one of those OCD spectrum disorders. This brings me to a term you may have heard in general medicine, but also applies to mental health: comorbidity. Comorbid conditions are two conditions occurring in the same person. They might occur at the same time, or one right after the other, and often exacerbate each other, or make each other worse. In our example of Rapunzel syndrome, trichotillomania, hair pulling, and pica, the consumption of non-food items, are considered comorbid conditions. Other mental health disorders with high comorbidity include substance use disorders and other mental health disorders, and even diabetes and depression. A local healthcare facility I used to work at actually started a program a few years ago designed to address this, creating a direct partnership between their diabetes intensive care clinic and mental health clinic. Back to our mental health disorders. A lot of folks don't know this, but there are some sleep disorders that are considered to be in the realm of mental health. Certain psychiatric disorders and sleep disorders are closely related, and psychiatric disorders are the leading cause of insomnia, which is the most common sleep-wake disorder. I think it's important for us to know a little bit about these conditions because let me tell you, when interpreting in mental health, you're going to hear about them. Not only are these disorders related to mental health disorders, but sometimes they can actually be side effects of common psychiatric medications. First off, narcolepsy results in excessive daytime sleepiness, or, an acronym for you, EDS, excessive daytime sleepiness. Many folks with narcolepsy have sudden sleep attacks. Then we have our breathing-related sleep disorders. If you've been interpreting in the medical field for any length of time, you're likely familiar with at least one breathing-related sleep disorder, like obstructive sleep apnea, in which a patient will actually stop breathing while sleeping. Parasomnias are a class of sleeping disorders characterized by problematic events that occur during sleep or sleep transitions. These are things like sleepwalking or somnambulism or sleep terrors, aka night terrors. Now, night terrors are different from nightmares. In night terrors, someone doesn't wake up completely, but they're usually very distressed, often crying, screaming, or both, and have a racing heart or are hyperventilating. This differs from nightmares in the sense the person doesn't wake up completely and usually doesn't remember anything from the episode. Infrequent night terrors in children are considered to be normal, but usually disappear by adolescence. Night terrors in adults, on the other hand, are usually the result of trauma and psychological disorders. So our last disorder in this category is restless leg syndrome, or RLS. It can occur while sleeping or lying down, and it involves an absolutely irresistible urge to move your legs. I'm speaking from experience here. Restless leg syndrome can and will keep you from sleeping. So as I'm sure you've noticed by now, there are a lot of mental health disorders. We've been through most of the major ones already, but there are a few more categories left. There are personality disorders. As you can tell from the name, these are pretty persistent to the point that the symptoms are seen as a central expression of the person as an individual, to the point where it's practically a hallmark of their personality, hence the term personality disorder. But these symptoms are problematic and dysfunctional and seen as maladaptive, another good vocabulary word. Some examples of personality disorders that you may have already heard of are borderline personality disorder, or BPD, antisocial personality disorder, and narcissistic personality disorder. There are more, 10 distinctive types in fact, so I'm not going to list them all or explain them all here. We also have our impulse disorders, also known as impulse control disorders. These are a lot of our manias, such as pyromania and kleptomania. You've probably heard of these terms, but if you haven't, pyromania is impulsively, there's that word again, setting fires or at the very least having the urge to. Kleptomania is compulsive stealing. Compulsive shopping is pretty self-explanatory. A common term used to describe folks with this disorder that you've probably heard is shopaholic, though someone can be a shopaholic without having compulsive shopping disorder. Of course, there are more disorders in this category as well. Now, before I put this last category up, I have to say it's very controversial. These are the paraphilic disorders or paraphilias. Paraphilia was a term coined as a non-pejorative, not derogatory, term to describe atypical sexual interests. It's important to note that over time, this category has had different names, ranging from sexual deviation to even sexual perversion, and used to include homosexuality and other sexual orientations and identities that we now know are not abnormal at all. It is important to know that this was a former miscategorization because this has been a source of persecution and trauma for the LGBTQ community. But we'll get more into this in a later installation of the series. I will say that these are some of the more difficult assignments to interpret for myself and for many others, these what are now considered to be paraphilic disorders. So it's important to be aware that 1, these types of encounters can and do occur in mental health settings, and 2, you should dismiss yourself from these assignments if you feel you are unable to remain impartial as per the medical interpreting codes of ethics. All of these disorders involve persistent patterns of sexual arousal that often involve non-consenting parties. Exhibitionistic disorder, sometimes referred to as exhibitionism, involves exposing oneself sexually to others in public places. Voyeuristic disorder, sometimes referred to as voyeurism, involves observing unsuspecting individuals who are naked in the process of disrobing or engaging in sexual acts. Pedophilic disorder, or pedophilia, involves sexual arousal towards prepubescent children. Again, controversial category, but I'm just sharing what appears in the DSM's and ICD's classification of mental health disorders and asking you to be aware of the possibility of having to interpret for such patients. And this is our very last category, finally, at long last. Each time I wanted to exclude a category, I really thought about it and said, you know what? I can't because XYZ. This category is no exception. Keep in mind that an earlier category we discussed was neurocognitive disorders and included dementia and organic amnesia. Those related to the neural processes related to cognition or thought. Neurodevelopmental disorders are behavioral or cognitive disorders that occur during developmental periods that cause some form of functional issues. Slight difference. So this category includes things like intellectual disability, aka intellectual development disorder. Now, this highlights the reason why I included this category. There is a facility I would interpret at called Mental Health and Developmental Services. It's not uncommon to have these specialties grouped together, as we can see here that mental health includes these neurodevelopmental disorders. However, this facility used to be called, and I will forewarn you here that I'm about to use a word that is now considered to be derogatory to illustrate a point. Mental Health and Retardation Services. That second to last word there, for those of you who are non-native English speakers, was in common usage, but is now very much taboo. Instead of saying it, a lot of people will actually just say the R word. I bring this up because, as we observed in the category of paraphilic disorders, our understanding of mental health and the mind has changed over time. The same can be said for terminology. What may have once been an acceptable term in common usage is now very offensive. We need to be mindful of these connotations when interpreting to and from English. So intellectual disability is characterized by significantly impaired intellectual functioning and behavior. Sometimes people will also refer to this as general learning disability. Here we also have our communication or speech and language disorders as well. We also have autism spectrum disorder or ASD, which is included in this category. Motor disorders are a subcategory of conditions in this category that cause abnormal and involuntary movements. They also include tic disorders, TIC, like Tourette syndrome, often simply referred to as Tourette's, which is a condition involving uncontrollable repetitive movements or sounds, including blurting out offensive words. Lastly, we have ADHD, or Attention Deficit Hyperactivity Disorder. Another reason why I didn't skip over this category because it might at first glance seem somewhat unrelated to general mental health interpretation. But I wanted to take the chance to point out that ADHD is a condition often treated by psychiatrists. A lot of folks are blindsided sometimes when interpreting in mental health. So it's important to prepare yourself for all these possibilities as best as you can. Well, we've gone over mental health disorders. Finally, we're done with mental health disorders. We've learned a lot of great mental health terminology, from not just the disorders themselves, but their symptoms and even related terms. But the fact is that patients, when talking about their experiences, will use a lot of words to describe their emotions. Those words that many of us learned as kids as those feeling words. Just as it's important for you as a mental health interpreter to know the technical terminology providers use, such as neurotransmitters and things like that, having a good working knowledge of your language in general, as well as an intimate understanding of the words used to describe emotions, is key. I could spend hours, and I mean hours, going over English words for emotions, degrees of emotional intensity, and the slight differences between what at first appear to be synonyms for the same type of feeling. But I'm going to leave this up to you. What I will do is go over some good sources of emotional vocabulary, starting with how we classify emotions. A common tool I've seen used often by therapists, counselors, psychologists, and psychiatrists alike when interpreting in mental health is Plutchik's Wheel of Emotions. I've even seen mental health care providers with pillows of some variation of this Wheel of Emotion. This is a way to visually organize emotions by intensity and even see how two emotions can overlap. Plutchik identifies 8 core emotions which come in pairs of opposites: sadness and joy, anger and fear, expectation and surprise, acceptance and disgust. So the way this works is you'll find the lower intensity or less intense emotions on the outside, whereas the inside, in the center, you'll have your more intense core emotions. Between the sort of little petals of our emotional flower here, you'll find what are called mixed emotions, or combinations of two emotions, where two emotions overlap. For example, aggressiveness is shown as the intersection of anticipation and anger. So let's take a closer look at our little wheel, because I know it's kind of hard to see here. So here's a zoomed in version of our little emotion wheel by Plutchik. Like I said, our most intense emotions are in the center, and as we move outwards, they become less intense. For instance, if something is bothering you, you're annoyed if it bothers you, but you might fly into a rage if it really bothers you. There are a ton of variations on Plutchik's wheel. I really like this one from Jeffrey Roberts. You can find it on Imager here. Examining these wheels and thinking critically about how to interpret them is a great way to expand your emotional vocabulary in both English and your target language, which is absolutely essential for interpreting in mental health settings. A simple Google search for emotion wheel will turn up a bunch of different variations with different vocabulary as well, and each variation may use different words, which is kind of like a rabbit hole of good mental health terminology. Our last segment is about acronyms in mental health care. When interpreting in mental health settings, you're not only going to see a lot of acronyms, you're going to hear them too. In case you don't remember, an acronym is an abbreviation of a concept formed from the first letters of the words for that concept. For instance, AKA, which I've used a lot during this presentation actually, means also known as. If there's one thing I've learned about US culture, especially US medical culture, it's that we're addicted to acronyms. So it's really important to be familiar with them. In this section, we're not going to go too in-depth into what each of these concepts means, because quite frankly, we reviewed many of them already. So first up, I'm going to go over some general mental health acronyms. Most of these you're going to see often. ACE, ACE, stands for Adverse Childhood Experience. This is the type of trauma that occurs in childhood. ACEs can include abuse, neglect, witnessing those things, or any number of things that would be traumatic and occur in childhood. ACEs are known to have a well-documented effect on a person's mental health, even into adulthood. Additionally, there is a diagnostic tool, a questionnaire, called the ACE IQ, which is the ACE International Questionnaire by the World Health Organization. ADL stands for Activities of Daily Living. This acronym is often used in physical rehab for patients who have had strokes or joint replacements, or for the elderly, but it's also used in mental health as well, especially in inpatient settings. These are just your normal everyday activities like feeding yourself, getting dressed, bathing yourself, etc. They can sometimes also be impacted by mental health disorders. BH is for behavioral health, but we've already gone over this. CSC is for Coordinated Specialty Care, and FEP stands for First Episode Psychosis. So FEP is right after DSM, but these two terms are related, CSC and FEP. CSC is Coordinated Specialty Care, and FEP stands for First Episode Psychosis. First episode psychosis is just that. The first time someone has psychotic symptoms manifesting or has a psychotic episode. We already discussed psychosis versus neurosis right after mood and affective disorders, and at the beginning of neurotic, stress-related, and somatoform disorders. Coordinated specialty care is a type of treatment program for people with FEP and involves specialists working together to come up with a treatment plan for the patient. So now remember, we discussed the DSM, Diagnostic and Statistical Manual of Mental Health Disorders, right before we got into our mental health disorders. MH stands for mental health, and we defined this in the very beginning right after we discussed our terminology resources. The PHQ is the Patient Health Questionnaire. It seems very vague, but it's actually a series of questions used to gauge a patient's mental health symptoms, specifically depression. There are different versions of the PHQ, like the PHQ-9, which has 9 questions, and the PHQ-15, which has 15 questions. In my experience, this is one of the most commonly used screening tools, not just in mental health care settings, but also in general medical settings to assess mental health symptoms. I've seen versions of the PHQ being used in physical therapy offices. PTS is simply post-traumatic stress. So we know PTSD is post-traumatic stress disorder, but what is it without the disorder part? Well, PTS is short-term and a normal reaction to traumatic experiences, whereas PTSD is a persistent condition and mental health disorder. RAISE, R-A-I-S-E, stands for Recovery After Initial Schizophrenic Episode. And it's a huge research program that examined CSC, Coordinated Specialty Care, and studied best practices. It was created in 2008 by the NIMH, the National Institute of Mental Health, and the project was designed to improve treatment outcomes for folks with schizophrenia. RAISE is important because its results are often cited and discussed by mental health professionals when planning care for patients with schizophrenia. SIB stands for self-injurious behavior. We briefly discussed this when talking about neurotransmitters, specifically endorphins. It's simply behavior in which a person harms themselves. WRAP, W-R-A-P, is a Wellness Recovery Action Plan. It's a tool to help patients take control of their recovery and wellness in terms of mental health care. This seems a little vague, but it's a specific system designed to help people feel better, feel empowered, and increase their quality of life through a daily maintenance plan, identifying triggers and recognizing early warning signs, as well as coming up with a crisis plan. Okay, so this is related to WRAP. This is a term that just came up. It's part of a WRAP plan. Identifying triggers. So obviously this is not an acronym, and surprisingly I've only mentioned it once thus far in this presentation, outside of WRAP, but as a verb. To trigger is to affect someone's emotional state, often significantly, by causing extreme distress. For example, someone who has been through a traumatic experience, such as being a victim of assault, may be or feel triggered by watching a TV show, for instance, that has a scene that depicts an assault taking place. This isn't restricted to trauma, however. Someone with an eating disorder may feel triggered by being bombarded with low-fat, low-sugar, and low-carb food options at a restaurant. Demi Lovato, who has struggled with bulimia, made headlines in 2021 for a similar experience. Now, this term trigger is often the butt of many jokes, and much like I mentioned earlier in this presentation about OCD, has become a bit of a fad. People without mental health disorders or a history of trauma will use this term to refer to seemingly mundane things for comedic effect. It's also often used to downplay real concerns in people who have mental health disorders. The fact is, trigger is a legitimate mental health term that is in common use in mental health care. Trigger as a noun is something that triggers. In other words, it's something that affects shifts someone's emotional state significantly by causing extreme distress. In mental health care, it's really important for folks who have experienced trauma or have mental health disorders like anxiety to know their triggers. For instance, I have a phobia of needles. Yes, I know, it's kind of silly for a medical interpreter to have a thing about needles. But by knowing my triggers, I know what my limitations are, what sort of situations I need to avoid, and what I can do if I'm ever unexpectedly faced with a trigger, because that does happen. That's how I'm able to interpret for biopsies, blood draws, and vascular surgeries without losing my cool. Lastly, as an adjective, triggering. Something that is triggering is either A, likely to cause someone to be triggered, or B, is pretty well known to cause someone to be triggered. For instance, needles, and veins specifically, are very triggering to me. I can handle auditory cues and graphic descriptions, but I can't see it or imagine it in my mind's eye. Otherwise, my heart will start racing and I'll begin to feel very anxious. That being said, needles in the skin. Think of like a TB test in your forearm. They're not triggering at all for me in most cases. And I can handle piercings just fine. That's an example of identifying and knowing your triggers. And lastly, this is the definition of trigger in a mental health context. You may also hear the word trigger used in general medical contexts as well. For instance, his bout with COVID triggered his liver failure. As in, his liver failure was caused by COVID. Or COVID was the straw that broke the camel's back and finally made his liver fail. Another common example is migraine triggers. Stress, hormonal changes, barometric pressure changes, bright lights, loud sounds, and strong odors are all common migraine triggers. That is, things that can precipitate or cause a migraine. So now we have some common acronyms for mental health disorders. A lot of these have been previously discussed, but I'll quickly go through and focus on the ones we haven't discussed. BD is bipolar disorder, one of the main mood or affective disorders we discussed. We also discussed BED, binge eating disorder, when discussing feeding and eating disorders. This is a little bit different from bulimia because it doesn't have a cycle of binging and purging. It's only binging. BPD is borderline personality disorder. It, along with, now we're going to the second column, PPD, paranoid personality disorder, and SPD, another one in the second column, schizoid personality disorder, are all, you guessed it, personality disorders. We very briefly discussed personality disorders in the slide More Mental Health Disorders, right before neurodevelopmental disorders at the end of our section on mental health disorders. Now going back to the first column, CD stands for conduct disorder. Now this is a category all on its own that we didn't really discuss, but they're often included in the same category as impulse control disorders. The ICD-11 calls it conduct dissocial disorder, and lumps it into a category called disruptive behavior or dissocial disorders. That also includes ODD, which is in the second column, or oppositional defiance disorder. In the ICD-10, ODD is included in the broad category of CD, conduct disorders. Very tangled web we weave here. Conduct disorders in general are disorders that result in persistent, age-inappropriate behavior, such as being dissocial, aggressive, or even, in the case of ODD, defiant or chronically disobedient. We've already been over GAD, generalized anxiety disorder, major depressive disorder, or MDD, and OCD, obsessive compulsive disorder. Oftentimes, you will just hear these conditions referred to by their acronyms. OUD is opioid use disorder, which is pretty self-explanatory. It's a substance use disorder in which the person is abusing opioids, such as heroin, fentanyl, and or pain relievers like OxyContin, Vicodin, or codeine. We really went in depth into PTSD, or post-traumatic stress disorder when discussing stress-related disorders, and also in our previous slide when differentiating PTS, post-traumatic stress, from PTSD, post-traumatic stress disorder. SZA is schizoaffective disorder, which is just another disorder that is included in the category of schizophrenia, schizotypal, and delusional disorders. This disorder is interesting because it has two types. One that is sort of a hybrid of schizophrenia and BPD, bipolar disorder, and another that is a sort of mix of schizophrenia and depression. So here we have acronyms for organizations and services that you'll likely hear being used in mental health interpreting, so it's kind of important to know what they mean. Some of these organizations have official translations of their titles, so it's important to use some of the resources mentioned in the first portion of this presentation to verify them. AA and NA, Alcoholics Anonymous and Narcotics Anonymous, are commonly used and referred to peer recovery groups for people with substance use disorders. AA came first and is a 12-step program designed to help people with issues with alcohol use and abuse to achieve and maintain sobriety. NA is another 12-step program, but it's for people who use or abuse other substances like drugs. The APA is the American Psychological Association. Enough said. Now, when you hear DSS, it's likely referring to the Department of Social Services. Now, federally, this acronym means something completely different, but at a state level, this is simply the state's Department of Social Services. A state's social services will provide many programs and services designed to improve the well-being of its residents. Oftentimes, this also includes counseling services or other mental health care services run by the state. Oftentimes, when a patient is in an inpatient psychiatric facility, when they're being discharged, they're given lots of resources, and oftentimes this may include a direct referral to the state's Department of Social Services or working jointly with the state's Department of Social Services. MHA is Mental Health America, which is a nonprofit organization, and it's sort of an advocacy organization promoting mental health and wellness. Their public outreach events and informational publications are widely dispersed. I often see their publications, their pamphlets, things like that in mental health care facilities. So sometimes you may have a provider say things like, well, here we have this pamphlet about XYZ from Mental Health America, for instance, or from MHA. Now, NAMI is a huge nonprofit organization, the National Alliance on Mental Illness. Actually, it's the largest US-based grassroots advocacy organization for mental health. It has many well-known programs, events, and publications, many of which are shared with patients in treatment for mental health disorders. The NIMH is the National Institute of Mental Health, which is a division of the US NIH, or National Institutes of Health. According to the NIMH, it is the lead federal agency for research on mental disorders. Now, a lot of this research is cited and shared with mental health care providers, patients, and their families. I also shared a whole bunch of these resources with you here in this presentation. So at some point, you will likely have to interpret this acronym. The NSPL is the National Suicide Prevention Lifeline. It's a US-based suicide prevention hotline at 1-800-273-TALK, T-A-L-K. Now, you don't have to remember the number, but sometimes you will see it referred to as the NSPL. A lot of times you'll see it referred to as the National Suicide Prevention Lifeline or the Suicide Hotline, but this is what they're referring to. They actually also now have an online chat as well if people don't want to talk via phone. So if someone is contemplating suicide or experiencing an emotional crisis, they can call or chat with someone to receive support free of charge. This is one of those resources that mental health care providers are always giving their patients. And a question I often get is help available in Spanish? So you got to remember, I'm a Spanish interpreter. So the answer for that is yes. Their website and hotline are available in Spanish, and there is an option for folks who are deaf or hard of hearing as well. However, I'm not really sure about their availability in other languages though. SAMHSA or SAMHSA is the Substance Abuse and Mental Health Services Administration. So it's a branch of the U.S. Department of Health and Human Services, or HHS, which you should know about as a medical interpreter. The HHS's OCR, or Office of Civil Rights, is in charge of enforcing many of the federal language access laws we should all be familiar with. SAMHSA was established in 1992 and is focused on improving mental health and substance use treatment in the U.S. Lastly, VA stands for Veterans Affairs. Also coincidentally, Virginia, which is the state where I'm located. But here, VA means Veterans Affairs. Now, this administers programs that helps veterans and their families. Unfortunately, it's not uncommon for veterans to suffer from mental health disorders and seek out mental health care. So here we have some acronyms for mental health settings. This is one of those slides I'm not really going to go over in depth because a previous installation of the series about the mental health care system in the United States, I discussed most of these settings in a great deal of detail. So we have CMHC, that's a community mental health center. Oftentimes, these are run by the county, the city, or the state. CSU is a crisis stabilization unit, and it's probably the only one of these acronyms I didn't really discuss in the aforementioned training, at least not outright. That being said, it's fairly self-explanatory. It's a type of residential treatment program for people experiencing a mental health or substance use crisis. So these are usually small facilities or departments that are usually less restrictive than a hospital. They're short-term and designed to, you guessed it, stabilize the person's condition. IOPs, intensive outpatient programs, and PHPs, partial hospitalization programs, are very similar in nature. And if you want to learn more, please go check out that other installation of the series I mentioned. IRF is an inpatient rehabilitation facility, and RTCs are residential treatment centers for long-term care. So we haven't really gone over different types of therapies. I will say, though I hear these acronyms on occasion, I rarely have providers explaining what these terms are or telling their patients what type of therapeutic approach they favor. However, it can be helpful to know the type of therapeutic approach that a provider will be using, because then it gives you a better idea of what sorts of questions you might have to interpret, as well as generally understand the direction of the therapeutic encounter. Cognitive behavioral therapy, or CBT, is perhaps the most common therapeutic approach I hear about. In cognitive behavioral therapy, the provider encourages the patient to focus on dysfunctional thoughts and thinking, with the goal of changing them. TF-CBT, on the other hand, is trauma-focused CBT, cognitive behavioral therapy, which means it's aimed at addressing those same things, but in a patient population with post-traumatic stress disorder or trauma. CET, or cognitive enhancement therapy, is geared towards people with schizophrenia and other cognitive disorders to help them improve their thought processes. Cognitive processing therapy, or CPT, sounds a lot like CET, but it's totally different. It's actually a type of CBT, cognitive behavioral therapy, designed to reduce PTSD, post-traumatic stress disorder, symptoms. See, we can talk almost entirely in acronyms now. CPT is a type of CBT designed to reduce PTSD symptoms. Boom. Anyways, DBT, or dialectical behavioral therapy, is yet another type of CBT. It was originally designed to help with borderline personality disorder and focuses on both acceptance and change. It's also been used to treat self-destructive behaviors as well as suicidal ideation. Electroconvulsive therapy, or ECT, is something some folks are surprised to find out still exists. It involves electrical stimulation of the brain and is often used in patients with bipolar disorder or major depressive disorder who have not responded to other treatment methods. No worries, patients are anesthetized during this process. Here we go again with another variation on cognitive behavioral therapy. MBCT stands for mindfulness-based cognitive therapy. Think of it as a combination between CBT and mindfulness practices. Mindfulness is another one of those key vocab words for mental health, and you're going to hear it all the time if you ever interpret in mental health settings. Mindfulness practices include things like meditation, yoga, and breathing exercises. And last on this slide, we have person-centered therapy, or PCT. Sometimes you might hear of this referred to as client-centered therapy. This is talk therapy in which the patient does most of the talking, and the provider really just listens, non-judgmentally, and may occasionally paraphrase what you say to try to understand you better. This is a less direct therapeutic approach and really leaves it up to the patient to come to their own conclusions and find their own answers through talking it out. I mostly have these acronyms here about mental health titles for your reference because I already discussed them in a prior installation of this series about the mental health care system in the United States. I do like having these titles handy and knowing what they mean because oftentimes I don't get a lot of information about a patient before I interpret for them. Sometimes I'm lucky if I get a name and a date of birth. Sometimes I just get the address to a hospital and I don't get told what department I need to go to. So sometimes I can be blindsided by an appointment. But if I have these acronyms, I might look at the provider's badge before we start the session. And let's say their title is LMFT. So if we look at this chart here, LMFT means they're a licensed marriage and family therapist. So while it's not 100% certain I'm interpreting for couples therapy, for instance, it might give me a good idea of what I can likely expect. So we have LCAT, which is a licensed creative art therapist. We have LCSW, which is a licensed clinical social worker, whereas a CSW is a clinical social worker. LICDC is a licensed independent chemical dependency counselor. We already discussed LMFT, licensed marriage and family therapist. You might see MFT, marriage and family therapist. So chances are if you see an L in front of something, that L probably stands for licensed, but not always. LMSW is a licensed master social worker, so that's a title, whereas MSW is a master of social work, so that's a degree actually that you can get, MSW. LPC is licensed professional counselor. LPHA is licensed practitioner of the healing arts. MHT is mental health technician, which we discussed in depth in the previous installation of this series. MHTA, mental health therapy aide. MPH, master of public health, that's a type of degree. MSSW is Master of Science in Social Work. Again, that's another type of degree. NPP is a title that stands for Nurse Practitioner in Psychiatry. Then we have PNP, Psychiatric Nurse Practitioner. So some of these titles will vary based on the state that you are in, if you're in the United States. QBHS is Qualified Behavioral Health Specialist. RN, which we should all know, is registered nurse. Oftentimes you will have registered nurses in inpatient psychiatric units. SCM, supportive case manager or management, whereas CM is case manager or case management, if you're referring to it as a whole. I would say this recording of this presentation, one thing that you can do is, if you really want to practice these acronyms, you can listen to this part of this presentation over again. Listen to me listing off these acronyms and what they stand for, and kind of doing a simultaneous interpretation over them, if you really, really want to drive them home. So now we have our ambiguous acronyms. So these are acronyms that when they're used, we often have to use context clues to figure out what they mean, or ask for a clarification if we're not sure. So we'll start with a tricky one, CPS. So when we hear CPS, most of us understand this to mean Child Protective Services, the organization that is called in cases of suspected child abuse or neglect. But in the context of mental health, this can actually be a title as well. Oh, we need to call CPS. Okay, they probably mean Child Protective Services, but we're going to bring in a CPS. Probably doesn't mean Child Protective Services, it probably means a certified peer specialist. So you never know. It's always best to clarify than to assume meaning. ED is a really great example of another ambiguous acronym. It can mean all of these things in a mental health context: emotional disability, emotional disturbance, or even eating disorder. But we're probably familiar with this acronym also being used to refer to the emergency department at the hospital, making it even more confusing. So if a mental health provider says a patient is in treatment for an ED, you're probably going to have to ask for more information. MI is another ambiguous one because in a mental health context, it can mean mental illness or motivational interviewing, which we've already discussed in this series. PT is an acronym medical interpreters are likely familiar with as either physical therapist, physical therapy, or even an abbreviation for patient. But it can actually mean primary therapist in a mental health setting. So if you're ever unsure, always ask. SAD. This one's tricky. It actually stands for 3 separate mental health disorders. Now, it's most commonly used for seasonal affective disorder, but sometimes you might occasionally hear it used for social anxiety disorder or even separation anxiety disorder. So as we can see here, these ambiguous acronyms can be kind of problematic. So these are now our commonly confused acronyms. 2 different acronyms that a lot of people think are the same thing. So ADD and ADHD often trip people up. Are they the same? Are they different? So ADD stands for Attention Deficit Disorder, whereas ADHD stands for Attention Deficit Hyperactivity Disorder. ADD is actually an outdated term. We typically use ADHD as an umbrella term to refer to any of these 3 types of ADHD. So we have inattentive, hyperactive, or impulsive, or combined. So inattentive ADHD is just like what it sounds like. A person has symptoms of inattentiveness or being easily distractible, but not hyperactivity or impulsivity. When people use ADD these days, more often than not, they're referring to this inattentive ADHD. Back to number 2, hyperactive or impulsive. Again, this one's pretty self-explanatory, I think. People with this type of ADHD have the hyperactive and impulsive symptoms, but not the symptom of being inattentive. Whereas number 3, combined, is, you guessed it, a combination of the first 2. They have the symptom trifecta of inattention, hyperactivity, and impulsivity. So this is another title. I've included this acronym because it's still in use in some parts of the US and relates back to something we've previously talked about. Remember, as the conversation surrounding developmental and intellectual disabilities has shifted, so too has the terminology being used in titles. Because of this shift, QMRP has gradually been changed in favor of less offensive alternatives in most places. What was formerly QMRP may now very well be QIDP, Qualified Intellectual Disability Professional, or QDDP, Qualified Developmental Disability Professional. Again, I include this terminology for educational purposes only, not meant to offend. Just wanted to make sure that all non-native English speakers were offered the same opportunity to understand this term in all of its contexts. So when interpreting in mental health settings, but especially when interpreting for psychiatry, you'll often hear these acronyms thrown around. These are two commonly confused acronyms. When you say them quickly, they can often sound the same, but there's an important distinction between the two. So these are two different classes of antidepressants. SSRIs are selective serotonin reuptake inhibitors. SNRIs are serotonin and norepinephrine reuptake inhibitors. So SSRIs are the first class of antidepressants that were in use, and they work by preventing the brain from reabsorbing serotonin through the reuptake process. So ultimately, this increases serotonin levels in the brain, which, if you remember anything from our discussion about neurotransmitters, is thought to be one of the neurotransmitters that plays a role in depression. SNRIs prevent the brain from reabsorbing serotonin and norepinephrine through the reuptake process. So, as a result, it increases serotonin and norepinephrine levels in the brain because, as we learned during our discussion on neurotransmitters, we know that norepinephrine is one of those neurotransmitters that is also thought to play a role in depression. So just kind of bringing back some of the stuff from our discussion about neurotransmitters, serotonin is thought to help the body regulate mood, whereas norepinephrine plays a key role in the fight or flight reaction, sleep, attention, memory, and mood regulation. So SNRIs are a newer class of antidepressants. Not new. They've definitely been around for at least a decade or two. But SSRIs were the first class of antidepressants to hit the market. Some examples of SSRIs include Prozac, its generic is fluoxetine, Celexa, its generic is citalopram, and Zoloft, its generic is sertraline. Some examples of SNRIs include Cymbalta, the generic of that is duloxetine, and Effexor. The generic of that is venlafaxine. If you're interested in learning more about mental health acronyms, you can find them at the sources that I used to prepare this presentation. These are really, really great sources. And you can see here, so again, if you found that my discussion here on mental health acronyms was not sufficient, that you want to know more information, definitely feel free to go browse these sources and learn a little bit more on your own. So that's all, folks. Now, not only do you have a bunch of mental health terminology, the resources to find translations in your target language, but also many additional resources to familiarize yourself more with the field of mental health. You've probably noticed at the bottom of each slide, there are tons of sources that I've cited. Like I said in the beginning, this is the most heavily cited course that I've ever prepared. So if you'd like to do your own in-depth investigation of any of the topics we've discussed today, you have some good starting points in those sources at the bottom of my slides. I hope you found this training to be informative and that it has helped expand your understanding of the field of mental health. Next up in the Mental Health Interpretation series for medical interpreters, Part 5, Trauma-Informed Interpreting. Most mental health care facilities and other facilities that provide mental health care services have adopted what is known as a trauma-informed approach. As an interpreter in mental health care settings, it's imperative to familiarize yourself with this approach that poses that recognizing and addressing trauma is central to the provision of mental health care services. We examine the framework of trauma-informed care, TIC, there's another acronym for you, and explore how we can adopt a trauma-informed approach to interpreting in mental health care and beyond, all without stepping outside of our role, of course. I'll bring in medical interpreting ethics as well, so this one will be fun. As always, stay tuned for the next part of the series.